So my name is Bob Gramling. I'm new here, so I've been here about 3 to 4 months, so thank you for this kind invitation, and it's a pleasure to be here today. I am in the Division of Palliative Medicine at the University of Vermont, their new chief, and the Holly and Bob Miller Chair of Palliative Medicine, a newly endowed chair. So that I can get a sense of the audience just a little bit, can you raise your hand if you're a clinician? Okay, can you raise your hand if you're not a clinician? Excellent, wonderful. Can you raise your hand if the only, no, I was going to say the only reason you're here is to get the licensure thing. I got here, and within a week I had 8 invitations for grand rounds, and I thought, wow, this is fantastic. This is just a thirst for palliative medicine. But it was curious to me that they all needed it by October 31st. And then by the 8th one, I finally asked, this is great, can you tell me the context? And they said, well, we all need it. So it was as usual, with everything in clinical care, it was quite humbling. So thank you again. My vision is terrible, so if you have questions, I would like you to interrupt me rather than struggle through the rest of the presentation if I'm saying something that's confusing. And what I'll need from you is to just raise your hand like that and get my attention. I don't consider that rude, I consider it inviting, so please, I welcome that. So compassion in palliative medicine. Good. I have no conflicts to disclose of the financial or ethical nature. Plenty of personal conflicts. If you have time, I'm happy to talk with you about those. This is what I'd like to try to get at in the next 50 minutes. I'm happy to go off-roading if people would prefer to do that without forcing it all in. But what is compassion and what is the link to palliative medicine? How common is compassionate expression in palliative medicine, particularly palliative medicine consultations in the inpatient setting? And what are some of the likely outcomes? Is it possible to measure compassion as a quality indicator, particularly as we become more incentivized to provide high-quality care to populations of people? This will become more important to begin to measure what is quality and what does it look like. And what is our approach to teaching compassion? And to invite your insights and your questions. So, compassion, lots of definitions. Since I'm presenting, I get to choose the one, and I'm sorry if this one is a little bit different than others. But I think Joan Halifax gets I think does a really nice job with this. And compassion can thus be described as having 2 main components: the affective feeling of caring for one who is suffering, and the motivation to relieve suffering. So how does this relate to palliative care? Turning to Medicare, which we don't usually do for pros, but they really, I think, do a lovely job defining palliative medicine, is palliative care, palliative medicine, means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. So to my knowledge, is the only discipline within medicine that is specifically focused on concepts of suffering. So maybe we should try to understand what that is. Eric Cassell published a seminal article in the early 80s that I carried around in my backpack that my lovely wife could attest to during medical school, and I read it frequently. Cassell says, suffering is experienced by persons, not merely bodies, and has its source in the challenges that threaten the intactness of the person as a complex social and psychological entity. So something that threatens us ourselves as people, as persons. Does anybody know what this is a picture of? Paint? Paint samples, yeah, that's right. Choosing the color of the living room, right. Yeah, this is kind of what it felt like. So very, very close. Anything else that makes colors on things? These are crayons. So in the early 1900s, when you're 4 years old, you had 8 choices. I want to make things one of 8 colors. When you're a child now and you reach for crayons, you got 512, unless you got the really beefed up set, and then you've got infinite number of mauve and other colors. So life is not getting simpler. The terrain in serious illness, the choices that people are making and the implications of those choices are not getting simpler. And as Cassell says, failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. I think Atul Gawande, in his book Being Mortal, which I'd recommend to anybody well, anyone who reads, how's that sound? And if you don't, you can listen to it. I listened to the version of this, and he's the narrator. It's quite lovely. I think he sums up a lot of the health services research of the last 20 years, is that particularly in end-of-life care, typically in the acute care setting, our decision-making in medicine has failed so spectacularly that we have reached the point of actively inflicting harm on patients. Not out of malice. That's not what he's saying. It's out of the systems that we've created and that we live with now. So over 2.5 million people died in the United States last year, and more are going to die every year, at least for the next 30 to 35 years. The good news is that we have lots of opportunity to get this right. In the last 6 months of life, people spend on average 10 days in the hospital. 42% see greater than 10 physicians in the last 6 months of their life. And 25% of the people die in the hospital. We have plenty of opportunity to do this well. We've been seeing an explosion over the last decade of palliative medicine in the United States, and particularly to address this challenge of end-of-life care. What has happened is we have, as I mentioned, exploded. We've begun to our science is just trying to catch up. So our science is early, but everything we have observed about palliative medicine is that A, it helps, B, it helps address concepts of suffering, and C, that high-quality communication appears to be the procedure, appears to be the active ingredient from which other things stem, including symptom management, decision-making. So our team is trying to understand, what does high-quality communication look like? Until we do that, we're not going to be able to tailor our training programs to best practices. We're not going to be able to scale what we do to meet the demands of a large population of people. So this is a screenshot of what our research assistants and coders will see. Our approach is to observe, usually with a nurse anthropologist in the room, observe palliative care consultations, record them with audio recording. We've tried video recording, but it's quite complex in the natural setting. And the standards of video recording for communication require multiple cameras on different people's eyes in order to track, in order to get that nonverbal well, and that's too much for the real setting of inpatient palliative care consultation. And what our team does is listens to these conversations and sees a transcript at the same time. And we train our team to listen for specific moments. We define them carefully. We practice 30 hours per concept in order to be able to have two people find it reliably. And there are some types of things we go after that are really hard to find. And we will not, and oftentimes we let it go if we can't get two people to hear things the same way, and because we're not trying to be mind readers. But for compassion, this is the definition that we've been using, Roshi Halifax's. And in it, there's two components. One is this feeling of caring for one who is suffering, and one is the motivation to relieve that suffering. Now, those are both internal states, and we can't tell that by audio. We don't want to try to estimate that. But what we want to do is try to find it when it's expressed. How would one human being express it to another verbally or in a way that we can hear? So these are the two definitions for our code book. One is that there's an expression of caring awareness that another is suffering. I'm aware, I see you, I understand what you're telling me, or here's my understanding of what you're telling me. And a motivation to relieve that suffering. And my intention is to help, and here's what I would suggest. So those two components are required for identification of compassion in our coding. And one of the ways to go after compassion is to first find moments of emotion. Other groups have called these empathic opportunities, when little glimpses of emotional suffering come to the fore, whether it's fear, whether it's sadness, whether it's anger, and measure the clinician, oftentimes the physician's response to that. And I'm not sure if people are familiar with this literature, but we've all been to see the doctor. What tends to happen if you express an emotion? You happen to do that? Anything? Any ideas? Just throw it. If I were to express an emotion in a clinical encounter, let's say in the hospital setting or in the office, what tends to happen? Any guesses? At least at the population level. Okay.
Or it depends on the clinician.
Good. Absolutely. So there's a lot of variability in what happens. What tends to happen, if you were to look at the normative reaction, is either to ignore it or move on, or to address it with medical information. That tends to be what typically happens. Not always, but typically. What we're seeing in the context that inpatient palliative care finds itself is that the vast majority of the responses do fall into the compassionate realm, and identification and recognition of suffering and intention to help when those emotions bubble up. So this is quite different, at least than what has been observed in other settings. And I'll give you some examples, a little bit of what I'm talking about, because that's a graph and it looks pretty, or my color choices may not look pretty, but clear. So this is an example of a gentleman in his 70s with advanced heart failure, and has had a 20-minute discussion of worsening shortness of breath, his treatments that have been failing over the last few months, and a worry about the future. And then the physician, I'll just read it here, says in this conversation, one of my jobs here, while we're getting the chance to know each other, however long that time is to help make sure that all of your energies and all your fight is going the direction you want them to go in. As your doctor, I'm here for you. From what you've told me, I know your struggle has been hard, and I want to help in whatever I can for you. So when you're listening to this, and if you're trying to find moments of compassionate expression, this follows an emotion, particularly a fear that has arisen in the conversation, and has the two components of, from what you told me, your struggle's been hard, recognition of suffering. Whether they use the word suffering or not isn't what matters. And an intention to help in some demonstration of a little bit of what that might look like. So this would count as a compassionate response if you're wondering what we were talking about. But what we're learning also is that these don't just come out of nowhere. Well, sometimes they do, but oftentimes they're fostered. So this is a gentleman who has metastatic lung cancer, and he's getting weaker, but he's not in pain. He's not having difficulty breathing. He's expressing awareness that he's going to die sometime soon, early in the conversation, but no demonstrable suffering in this early part of the conversation. But what he says to the physician at this point is he's been working hard to convert this doc, subtly or explicitly, to born-again Christian status. If you want to see a doctor run out of a room really quickly, try to convert them. But what was lovely was sticking in there. It was quite a fun exchange. But the patient at one point says, "My fellow Christians come to visit and they see me." And the physician responds by saying, "You speak about it so beautifully, and thank you for sharing with me." And the patient said, "It's a warm feeling." So what does that physician response do right there, would you imagine? Anything? Yeah, I'm ready to hear you. I'm ready to. I'm in this with you, and it's okay. The things you're telling me, I'm actually welcoming them, appreciating them. I'm not saying that I'm going to convert, and I'm not saying that I necessarily agree or not. But I think it's beautiful, and that you're sharing with me. What these things tend to do is these tend to precede what we find as the compassionate expression. In fact, what happened in this conversation, you then start to see things unfolding, particularly with regrets about the way he has lived, concerns about legacy, existential forms of suffering that come out. But these things were findable. We tend to call them invitation to compassion as a thing we were finding. But then what happens also is after a compassionate expression tends an opportunity for beginning to get to know that person and that self a little more. So here's an example of what I'd see as a little bit of a follow-up. Is This is with a woman who has metastatic breast cancer. She's considering third-line chemotherapy and is in severe pain from metastases to the bone. So the physician, what are some of the, earlier in this conversation had been a number of compassionate expressions, so this is a little bit of a follow-up. So what are some of the things you were hoping to do? Patient, get the pain under control so I can go shopping and stuff. Physician, okay. I want to see my son. I don't want my son to see me on the couch all the time. He's got anxiety, he's got disabilities, he's got behavior problems. Physician, so getting the pain better so you can move around a bit and appear more comfortable for your son is one thing to hope for. Yeah. So then the rest of the conversation tends to be about how do we achieve that and what can it look like. And so what this begins to demonstrate is some evidence of getting at it a little bit more, starting to understand the person a little bit better in their context and begin to navigate those terrain of options that those crayons presented for us. Questions so far?
You mentioned existential suffering, which, can you just talk about that a little more? It's kind of a big concept for African.
Yeah, I love that word, so I sneak it in as often as I can, and I'll talk about it a lot. Can we define it? Not really. Even the existential psychotherapists will all root this to death-related terror. That tends to be where the roots of the discipline tends to emerge. I think it's bigger than that, and I think it's wider than that, but they tend to be concepts of suffering about meaning, either the way one has lived their life and having to reconcile that, what their memory of is going to be, their legacy. Is it going to be meaningful for their children? The fear of dying or after death, questioning to a pretty intense level your beliefs that you had always held about what the afterlife might be and wondering if in fact you're close to it. So these tend to be the domain of existential distress or suffering. I've tried publishing a few papers calling it that, and the reviewers haven't given me a lot of latitude, so I have to come back and snap it into something a little bit more definable as a set of symptoms. So I'm glad you picked that up. It's a concept that is important and we all gravitate to. Defining the boundaries is pretty tough. Right. So what we're moving our research now from a cross-sectional look at palliative care consultations to longitudinal cohort studies, to beginning to understand what are the predictors of communication and what are the outcomes of communication, with the purpose of identifying what are the features and types of conversations that seem to foster the outcomes that we would want to see. And we could all list them, and they're the types of things that we would measure, all within the umbrella of patient-centeredness, and all of which will track on to concepts of suffering. So we're done with recruitment and follow-up at this point, but we've just finished, and it's an observational study funded by the American Cancer Society. It's hospitalized patients with stages 3 or 4 solid cancers who are referred for palliative care consultation. They're not enrolled at hospice at the time of the referral, and they speak English. It is a simple study. For researchers in the room, we call it elegant. The patients are enrolled at the time of referral for palliative care consultation. The first 3 visits with the palliative care team are observed and recorded, or up to the first 3 if there are 3. Patients are interviewed before and after, and telephone and medical record follow-up for 6 months. That's the gist of the study. So we have 383 goals of care conversations, one of the most common reasons for palliative care referral in the hospital setting, with 241 hospitalized patients with advanced cancer, actually 240, and 56 palliative care clinicians. 133 clinicians total, 56 of them being palliative care specialists. And this was done in Rochester, New York, my previous institution, and in San Francisco, California. So we worked hard to this is a population who is quite weak, and engaging in research can be challenging, and because of that are often missed. Their experiences are often harder to capture in understanding what it is we do and what is of benefit. So we worked very hard to make participation easy, to keep the burden low. And so people only had to answer 20 questions total. The rest we would get from the medical record or other sources with a reasonable degree of validity. But these 20 questions are the ones you really can't get anywhere else except from asking the person. The people enrolled reflected almost identically the demographics of the two hospital systems from which the referrals arose. And our recruitment rates were very high, and participation rates were about 8 out of 10 for every person who was approached. The thirst for participating in communication research was very high among patients and families, especially if there were no interventions and they just said that we weren't doing anything different other than the observing part. As I mentioned, we included people with a solid cancer, so this excluded the blood-borne or the blood-related cancers and some of the lymphomas. I'm not going to read all of them, but you can see that the cancers of the lung were the most common, followed by cancers of the GI tract, or GI tract being the most common, but individually broken up, and then many others. The survival for time for people who are referred to palliative care in the hospital oftentimes look like this. Usually about half of the people we see will die within the next few weeks, between 3 to 5 weeks as we see here, and very few live beyond six months. And that's what we see here for our sample, meaning that we're capturing the people who typically see us in the hospital setting. And trying to get at when we think about compassion, one of the pieces to understand is what does the terrain of suffering look like? If we want to understand compassion in this setting and what matters, trying to understand the dimensions of suffering. Now, asking about suffering is hard to do, especially if you have 20 questions on a questionnaire. But we're using what the Dartmouth co-op charts have done by using the how much are you bothered by, which I think is a really, well, obviously I like it because we chose it, but by using the bothered by, I'm not asking about the frequency or intensity of a symptom. I'm asking to the degree to which it is bothering them as a person. Now, there's no level of this that will define when someone's suffering or not, but it is getting at their judgments about how they're feeling with these types of symptoms. So, over the past 2 days, how much have you been bothered by physical problems such as pain, upset stomach, or difficulty breathing? And you'll see that nearly 70% of people are quite a bit or extremely bothered by physical symptoms, with over a third extremely bothered. And the co-op charts do identify that threshold as anything worse than moderate, depending on whichever way the scale is set up, as being an indication of clinical importance, and extremely being certainly a clinical priority. So if you're trying to understand the thresholds of clinical meaning, those tend to be the ones that we've been finding. So for emotional problems such as feeling anxious, depressed, irritable, and downhearted and blue, I didn't actually like that question very much, I have to admit, but that's the one they've been asking for 30 years and it's been working really well, so I was not going to try to reinvent that. And everybody understood it, so it was great. We find here that about almost 1 out of 5 people have extremely, and about a half are above the clinical threshold of moderate. Now, I'm calling this spiritual element. That's giving me a little bit of latitude. It's actually a peace screening question developed out of Duke. It doesn't define the dimensions of spirituality, nor necessarily define what peace means, but tends to find it gets at things a little bit differently than the first two do. So over the past 2 days, how much have you felt at peace? And you find that about 1 out of 5, again, are not at all, and about half are slightly. The interesting thing is that the people, although the distribution looks pretty similar for emotional and spiritual, in the Venn diagram does overlap. These are not the same people. So it is capturing a little bit of a different phenomena for some respondents. So the McGill Global Quality of Life item is oftentimes used to address a global gist of where people are with respect to their quality of life. Considering all parts of your life, physical, emotional, social, spiritual, and financial, over the past 2 days, how would you rate the quality of your life? Now, the colors here are to represent the distribution of responses in our sample. What you'll find, even among very sick populations, is that blue to purple range tends to be much bigger. People tend to rate over 5 when given the opportunity. So having 2/3 of people rating 5 or below is a substantive message from people participating in our study. But what we're interested in is trying to get a sense of these dimensions that we've asked, the physical, emotional, and spiritual, which are drivers of these global judgments. So what we did is compare the quality of life responses among people who are in the green domains of those bar charts compared to the people who are in the gray domains of those bar charts. And what we saw in the physical domain about people who are in the quite a bit to extremely range of being bothered by physical symptoms had on average about 1 point lower levels of quality of life. Whereas in the emotional and spiritual is about 4 times more, which tends to be a little consistent with if you were to ask clinicians about their experience with suffering in patients, that the emotional and spiritual domains are big in people's judgments of quality of life. So this is consistent. What becomes important when we think about trying to track things like compassion and suffering, what are some of the outcomes that we might want to be looking at? And to do that, it helps us to break down a little bit about what reducing suffering, how we can do that. So reducing suffering, if suffering is a threat to self, there are really 2 general approaches. One is to reinforce the self, to shore it up, to celebrate it, to identify it. The other is to remove threats to self, things that are threatening. So both of those things require us to understand the self enough to be able to target both of those. So one of the measures that we use as a proximal measure of communication is to how well it fosters a sense of being known. And this is asked in different ways. The way we have been asking it in our studies is, over the past 2 days, how much have you felt heard and understood by the doctors, nurses, and hospital staff? Now, we're interested in the global environment, not specifically about how much did Bob or how much did Sarah or whoever understand you. We did pilot some of this, how much did X team, or do you feel, and as you might imagine, a lot of people didn't really have a clue about who you were and which team you were from. It was just a big glamash of people coming in white coats or non-white coats. So this actually was much easier for patients and families to respond to confidently. And it didn't have as much concerns about the social desirability. I think we all know if you're receiving feedback of patient reports of your care, how much they like you or how much you get reported, they have very high ceiling effects on those reports. People are very forgiving in the memories, and when they're responding, how well did your doctor do, they tend to go really high to the point where it's pretty hard to measure things that all hit that ceiling. So in this, we do see, however, a distribution of responses. This is at baseline when people are enrolled over the previous 2 days. What we see is anything other than completely tends to be a message. So about 2/3 of people are saying as if there's room for us to improve here. All on the higher end, as we might expect. 1 day after the recorded conversation, the first recorded conversation, we see these numbers moving up. Not all there. We don't have 100%, and we're not done. But what we're finding is that about 56% of people who reported feeling incompletely heard and understood at baseline improved on their follow-up. Now, we don't know how much of that would happen if you asked the same question twice of people, no matter what you did in between. But my hypothesis, based on what we see in the natural setting, is it's probably not this much of a jump. What this points to, something happening in these conversations is likely going to be able to be measurable with respect to changes in this dimension specifically. So one aspect of the research we're doing is trying to prepare ourselves to measure quality. And palliative medicine has a large national conversation going on about what does good look like? How do we measure it? And how should we be rewarded for achieving that? And so one of the good news is this measure of heard and understood is now accepted as, in the National Quality Forum, as one of the measures of inpatient palliative care that institutions will begin rolling out, if they choose to, as a measure of addressing or first steps towards addressing suffering. And it also will track nicely onto compassion for studies of compassion. Tiring out? More research? Okay, we'll go one more research, okay? Then we'll move into other things. But this research is kind of fun, mainly because I don't understand a lot of it, but it really looks cool. So one of the things that I've been studying conversations by training people to hear things. And I've been intrigued when my kids play with my phone and do stuff on it. I'm noticing more things like Siri and the artificial intelligence of computers to be able to analyze meaning in conversations. UVM has an extraordinary group of computer scientists who measure complex systems, usually about the environment. What's the habitat like for some species? A conversation is much like an ecosystem. It's an organism to some degree that's very complex, and it exists in some contexts, and depending on that context, it either flourishes or doesn't. And so I approached them to say, hey, I've got these audios. I'm not so sure, I don't know anything about a computer, but what do you guys think you can do with them? And it's been fantastic working with Maggie Epstein, Donna Rizzo, and Victoria Manukin. What we're doing is we're able to already, just off the shelf, other people can have developed algorithms for identifying emotion in human speech, regardless of whether you can recognize the words. What we're focusing on are related to compassion, but it's silences. One of the things we've noticed over the last few years is that we can oftentimes find these moments of compassion by focusing on the silence. And silence tends to have a different shape from a computer point of view. The sounds coming into a silence, the sounds coming out of a silence. Who's speaking at the beginning, who's speaking at the end? Is there fear at the beginning, is there fear at the end? And what we're able to find is there's typically three types of silence. One is distracted, and the one good cue for knowing when that is when you hear computer keys typing in the background during the silence. Another one is awkward, just stuff happening and I'm not sure what to do. The other is contemplative. We're just naming it that, but providing space for something to be, particularly some form of suffering or some recognition of new information. And those contemplative silences, they just look different to a computer. So we can begin to find them. And so what we're starting to do is train our algorithms to see if we can find contemplative silence. We're doing it a few ways. Have some music students who put conversations to music and just musical notation. Others who graphed participants based on the colors of them and when they showed up, and the actual audio signals. And we're using those things to train neural networks. They call it deep learning at this point, to begin to identify silences. Now we're far off from being able to do this well and reliably, but what it's starting to get at is it may be possible to begin to measure communication in real time, confidentially, about what quality might look like as our science matures and the ability to even know such things. So that's my cool slide. And I hope there's no computer scientists in the room because I cannot answer anything what's going on behind the scenes other than a complex algorithm. So, teaching. So one way to promote compassion is to measure it and to reward it. And so we're working on that as well. Another way is to teach it. Sometimes teaching is modeling, just having people with you, being able to see. I remember very clearly seeing the first time I saw a physician engage compassionate. Well, the first time was my father. He's my hero, and I thought all doctors were like him. And when I got to medical school, I remember calling home and saying, where'd all these other people come from? I like doctors, but they're not all enlightened like the person I grew up seeing as a doctor. But what one of the things is just to be able to model it. Say, see, this is something you can do. It's not hard. You're a human being. You probably did this better before you went to medical school. But when we teach it, we then have to become a little more explicit, to break it down. When people are learning to do something, the one thing we don't want to do, and I think we've all experienced this with teachers in our lives, is say, this is really hard and you'll never get here. And I want you to appreciate how good I am at something. Well, that's not helpful at all when you're trying to learn something new. Let's break it down. Let's make it achievable. Let's start to learn our way along. So one of the first steps we find, both with medical students and up through training up until palliative care fellowship, is that we need to think very clearly about empathy and compassion, at least the way they've been operationalized the last 20 years. There's been a move towards empathy in medical training. And that's good, right? Empathy is the ability to experience another's suffering or another's experience. But it's not good unlimited. And so a lot of the training on empathy, we've had students say, if I'm going to be a good doctor, if I'm going to do this really well, I have got to just work on empathy. That's what I got to do. And for some people, that's really, really helpful because they're starting from a place that they actually need to learn some of these things and actually get a sense of what another person is experiencing. But for a lot of people, they're kind of already there. And working to focus on experiencing another's suffering is a quick way to burnout. It's depleting. What we want to move towards is compassion. And compassion is understanding someone's suffering enough to get it, to be able to understand it, but be able to use my clinical brain in thinking about how can I help that and to express that helping. And what we find, and I think that Dalai Lama and some of the mindfulness people have been talking about this for decades, is that compassion, unlike empathy, is revitalizing. It's not something that depletes you. Neuroscience is starting to show that. So some of the training in empathy and compassion training, what we're finding among trainees is that the parts of the brain that light up in people who've been trained in compassion training compared to people who've been trained in empathy training, for the same exposure of suffering, the empathy training people light up in the pain centers. The compassion training people light up in the pleasure centers.
And yet we call it compassion fatigue.
Exactly. I'd rather call it empathy fatigue, right? And so this is important. Oh, that's my cue. Thank you very much. That's my 10-minute. Thank you. Okay, good. So this is an important distinction right at the beginning. And for some people who haven't do it, are trying to figure this out a little bit, I have a couple of movies. I'll say, hey, if you want to go watch a movie, there's a movie called Powder. It's about a young person who experiences all the animals' pain around them and can't function in society because if he sees a dead animal or sees an animal in pain, just cannot function. And so it's a quick way to see, okay, that's something a little bit different. But then what we do is start to say, okay, this is a conceptual model that we use, or we developed and use in our research, of conversations. Up until pretty recently, any communication research that's been funded by NIH has been a kind of a public health model. I say you do. I put it on a billboard and you do it or you don't do it, and that's what communication has been. And so by creating this, it can be very frustrating for people to look at because the first thing they say is, who starts? Who follows? It's a beautiful thing to get someone right at the beginning to say, this is a dynamic thing, it's relational, and it's participatory. And it's not me say you do. It's a participatory exchange. So just starting there can be a little freeing for people and scary. But then we break it down into micro skills. And so specific for compassion, we have a palliative medicine course in the third year of medical school now. It's actually brand new this year. And the first day is going to be on compassion training. And so the first half of the day is going to be beginning to develop understanding of what concepts of suffering might look like, and training excellent standardized patients to express different forms of suffering in a safe environment so students can see and feel what it looks like. And to practice 3 specific steps. One is turning toward, another is diagnosis, because medical students love to diagnose. But I'm going to have them diagnose suffering, not disease, not even illness, but we're going to diagnose suffering. And then the third is intention. And so to practice 3 steps. And so turning towards, for example, we can write about it. A colleague of mine, Ron Epstein and Tony Bach, have written on turning toward means recognizing suffering, becoming curious about the patient's experience, and intentionally becoming more present and engaged. So first in the morning, the first hour is going to be exposure to suffering, and we're going to give them 10 turning towards statements and say, pick one, whichever feels good to you. Try it out. They can say rewind. The standardized patient can do it again. They can pick another one. The idea is to get enough experience of a turn toward instinct instead of a turn away or run away instinct. In the turning toward instinct, none of the 10 options are, oh, it's going to be okay, because that does not fit well with turning towards suffering. We don't know if it's going to be okay. And if it's going to be okay, it's probably not going to be because I patted you on the head and said it's going to be okay. That feels a lot like pity, and if you really want to piss someone off, say that to them when they're suffering. So that's one of the things we really work towards identifying. What did it look like, that first step? Then we debrief, talk about it, how did it feel, what were your instincts, how do we move from that? And then we come back after a nice lunch. I'm sorry. We don't come back to mindfulness. And work on the next step. So we time back in and say, okay, we've turned towards this. get a little bit of more of the patient's story to begin to diagnose what is the source of suffering for this human being. Talk about it. And then practice 10 statements of intention, of compassion. Choose one. Response to this situation. Practice a few times. So in the communication training, it's really providing a roadmap, micro skills, drills, coaching, and reward, and modeling. And these things can be taught if they want to be taught, if people want to learn them. If you want to sustain them, we're learning more about concepts of mindfulness, which have two key components. One is attention. So if we're doing this well, we're fully present amid suffering, and that can be hard. It can be important. And if you're doing it all day, if you're in the 5th family meeting with a different set of in-laws, with different sets of questions, it can be hard to stay in the game. And so training yourself to be able to attend in real time and not think about what you're going to have for dinner or what you did wrong yesterday or whatever it happens to be, that takes training. As does the other aspect of mindfulness, which is recognizing your emotions and letting them go, at least in the moment. Is saying, wow, I am feeling kind of angry right now, or I'm feeling kind of sad right now. I'm feeling kind of, we don't say it that way, but then let it be. Let it settle, get back in. Those are the two components of what mindfulness is. So a lot of medical communication training incorporates aspects of this in a very secular way. 5 minutes, good. Sorry, I'm using up the, I'll get blast through the summaries, which you already know anyway, so we can talk about it a little bit. So the pieces that we talked about today is just that compassion and palliative medicine are linked by a purposeful approach to understanding and reducing suffering. That suffering and compassion are common in palliative medicine settings. Palliative medicine consultations appears to foster proximal outcomes of compassion. That measuring compassion and compassion-related outcomes is possible and important, and teaching compassion is possible and important. Questions?
Here's a comment more than a question. I find it interesting that the authors of the study just showed we're all men and not women, yet almost exclusively here they're women and not men. And
Which study are you referring to?
the last, one at the very end. One at the very end. Yeah, that one.
Oh, the authors. Okay. Yeah.
I just find it interesting because as we know about right brain and left brain and women versus men, and that I think that if somebody learns compassion as a tool for potentially gaining trust of their patients, it can look rote versus somebody who truly has a inflection and a tone and eye contact and body stance that demonstrates compassion.
Thank you. So since I study conversations in my clinical role, I can't help but being part of conversations where I'm like, shit, if I use that measure, that would have got all really high marks. And that was an abysmal conversation. Or the reverse. This was touching, it was tender, this was beautiful. And it wouldn't have triggered any of the measures of what good looks like in some other people's measures. So in fact, some of the things you're talking about is why our team has moved away from some traditional measures that have a valence to them, good or bad, and try and stay solidly in describing what we see. And we find it much better at starting to capture what you're getting at, is the actual behavior or the moment we're looking for, and not whether the whole package was good or bad. Because just like you're saying, we found the same problem, that you can put the package together in ways that doesn't work, like the sum of the. Please, yep.
So in the cancer community, when should palliative care be introduced?
This is a national conversation, so I'll give you my opinion, and I think palliative care can be helpful when somebody involved in that person's care, including the person, feels like they're suffering, or that there's potential suffering ahead. And I don't use that word because suffering tends to trigger euthanasia in people's heuristic understanding of that word, because it's used mostly in veterinary medicine, to be honest. But a lot of the structures of when to refer to palliative care, most of the ones that we're evolving to nationally are using a surprise question. Would you be surprised if this person dies in the next year? And if the answer is no, regardless of whether they do or not, that's probably a time when it's useful to have good attention to palliative care, whether it's done by a specialist or a generalist. That tends to be some of the triage things that we're thinking at a population health. There's nothing magical about that other than trying to get a sense that it's usually towards the latter part of someone's life that we're going to probably have the biggest benefit. That's my opinion. What's that?
What word do you use instead of suffering?
I use suffering sometimes purposefully. You know, I'll make the judgment, and it's almost a therapy judgment, is throw that word into the mix and see what people say about it in clinical interactions. But I'm just going to say I don't know. I've had a couple of students observe me for a semester in their communication courses, and they do a thesis on clinical communication. And I used to think I knew what I did, but after having 2 students come by and report what they saw, I was astounded by it wasn't all congratulatory, I can tell you. And it gave me some humility in knowing exactly how things unfold. But I do know that when I use that specific word, it's purposeful in a therapeutic way of trying to get that out there in a conversation.
I'm an oncologist, so I deal with a lot of palliative care issues and such. But
Thank you.
what strikes me is that a lot of times, even for very older patients or patients who've been through treatments and such for many, many years, they don't have the acceptance of the death event. And, you know, I'm Eastern European, we have a little bit of a different approach culturally, but I find that patients here are just not accepting death coming. And I don't know exactly why that is. They just don't want to acknowledge it, don't want to talk about it, or just not accepting it to the point where they want more and more aggressive intervention, although it would not be necessarily good for them. So I don't know where that comes from. I don't know if you can enlighten me a little bit.
Well, enlighten you. If I had that power, that would be wonderful. I start with myself first. I think a couple things that we see a lot is, one is that word acceptance is not one that I personally revolve my practice around. There's plenty of people who we do a phenomenal job with, who we address suffering well, that have no acceptance, nowhere close to it. They're going to slide into home base, you know, just cigarette in hand. You know, that's the way they're going to finish their life, right? And our job at that point becomes, how can we minimize the fallout? You know, so what does suffering look like to you? I haven't met anybody who doesn't have a degree of fear about dying, who is looking for aggressive treatments. And so when we look for that, we just identify what does suffering look like to you, and how are we going to know how we can mitigate that? And sometimes it's to the point where they say, you know what, I'm in a lot of pain, I can deal with that. I want to maintain my functional status high enough to keep getting whatever chemo they're going to offer me. But when the time comes I can't speak for myself or I'm in the ICU, I don't want my family having to make decisions for me when I can't be making them anymore. So we can give voice to that. We can say, okay, this is where it's headed. I mean, we do think that's, you know, I often invite, would it be okay if I share with you what I expect or what I foresee is likely to happen so that we can prepare? And if you don't want to talk about it, there's someone in your gang who would like to sit with me and we can talk about it and think about recommendations. But it usually comes to some hard stop where we can have some voice, but not always. As you said, there's plenty of times where people just don't want to go there, and all we can do is keep offering in a way that's inviting and not a hammer. Okay.
I just admire what you're doing. I must admit, I'm a physician, and I thought a little about the science of compassion and suffering. It's odd for me to think about it, because for me it feels real. And when I see the word mindfulness up on the screen, mindfulness is really not usually
Is not what?
I don't define it as being scientific.
Right, right.
It's so separate. So I commend you in taking on this job of teaching the science. And I suspect trying to appreciate the mindfulness and the innateness of caring and of understanding suffering.
Thank you.
I have one announcement.
Yes, please.
It is the lunch session hour, and the lunch tickets for either the big lunch, which is upstairs in the demo room, or the grab-and-go in the big lunch.
Thanks. Thanks, Todd. I'll be here for a couple minutes if you have thought.